So let's talk about intravenous anesthetic agents today. And before that, let's classify the anesthetic agents into 6 types. So the first type is alkyl phenols. Alkyl phenols. Example is your propofol. Propofol. Then the second type is barbiturates. Barbiturates. The example is thiopentone sodium. Thiopentone sodium. Thiopentone sodium. Or methohexital. Methohexital. Alright. So the next one is benzodiazepines. Benzodiazepines. The examples are midazolam, diazepam and lorazepam. Midazolam, diazepam and lorazepam. Alright. Then comes the phencyclidine derivatives. Phencyclidine derivatives. Example is ketamine. Example is ketamine. Then we have something called imidazole derivatives. Imidazole derivatives. The example is etomidate. Etomidate. Then there are some other miscellaneous drugs. Miscellaneous drugs. The examples are dexmedetomidine. Dexmedetomidine. And there is droperidol. Alright, let's begin with the first drug, which is propofol. So moving on with propofol. As I already told you, propofol is an alkyl phenol. Propofol is an alkyl phenol. Now, how is this drug available in the market? Availability. 1 ml of propofol liquid in the vial contains 10 mg of propofol. 1 ml contains 10 mg of propofol. Now, how does it look like? It looks like a milky white liquid. Milky white solution. Milky white solution. This could be an image-based MCQ. Okay, milky white solution is propofol. Then it is available as 1% and 2% solutions. 1% and 2% solutions. Alright, now what is the composition of propofol? Composition of propofol. It contains 1% propofol. 1% propofol, which contains egg phospholipid. Egg phospholipid. And there is high chance of bacterial contamination for propofol due to this reason, that it contains egg phospholipid. Bacterial contamination. Alright. Then there is glycerol. Then there is 10% soybean oil. 10% soybean oil. And this is the reason why the propofol injection is painful. So propofol injection is painful. This is a previous year question. Which of the following is a painful injection? Answer is propofol. Okay. Then there is EDTA or disodium edetate. Okay, disodium edetate. What is the use of EDTA? It will prevent the bacterial contamination. It is a bacteriostatic. Bacteriostatic. I hope this is clear. Alright. Now let's move on. Let us know more about propofol. See, propofol is a highly lipid soluble and water insoluble compound. Highly lipid soluble and water insoluble compound. Okay, but there is a water soluble formulation is also available. Water soluble formulation is also available. Water soluble formulation is also available in the market. It is known as phos-propofol. What is the advantage? Because the phos-propofol is not painful. There is a non-painful formulation also. Not painful. Alright. Now what is the mechanism of action of propofol? What is the mechanism of action? It mainly acts by enhancing the GABA mimetic action. It acts by enhancing the GABA, which will lead to the hypnotic effect, which will cause the hypnotic effect of propofol. But there is also a line given in Miller's. Saying that there is an inhibition of NMDA glutamate receptors also by propofol. But the main action is always GABA mimetic. Okay. Action of propofol. Alright. Now what are the pharmacokinetics of propofol? What is pharmacokinetics? Onset of action, it is about 15 to 30 seconds. Alright. Then what about duration? It is about 5 to 8 minutes. Why so less duration? This is due to redistribution. This is due to rapid redistribution of the drug. Alright. Then what about metabolism? The metabolism of the drug is in the liver. Not that it is not there in kidney. Liver more than kidney, more than lungs. Clear? Then what is the elimination? Elimination half-life. It is about 4 to 7 hours. Clear? Then let's move on to the pharmacodynamics. So in pharmacodynamics, let's deal about CNS first. CNS, we already know that it has a GABA mimetic action, which is causing the hypnotic effect of propofol. Clear? Next, it decreases the serotonin. It decreases the serotonin levels. In area postrema. Area postrema, we already know that it is linked to vomiting center. So decreased serotonin level, which will lead to anti-emetic action. So propofol is also having an anti-emetic action. Then what is its action on the cerebral perfusion pressure, cerebral blood flow and all? So it decreases cerebral perfusion pressure. It decreases the intracranial pressure. Decreases the cerebral metabolic rate, and also it decreases the EEG activity, electroencephalogram activity. Is this clear? So it has a cerebroprotective effect. But there are reports that propofol will also cause neuroapoptosis. Some reports suggest that it also causes neuroapoptosis. So this is a controversial topic. It is still under research. It also causes neuroapoptosis. Is this clear? Then it has an anticonvulsant effect. Propofol has an anticonvulsant effect. But propofol is not an analgesic. It causes pain on injection, but it is not an analgesic. It is only a hypnotic induction agent, not an analgesic. What is the major source of analgesia in anesthesia? It is opioids. Opioids will give analgesia. Okay. That is about CNS. Then let's move on to the respiratory component. So basically propofol is a respiratory depressant. Respiratory depressant effect. So when you give the induction dose of propofol, patient will go into apnea. How you will assess? By asking the verbal effort of the patient. By asking the patient to count 10, 1 to 10 or 10 to 1. By asking his name, place, everything. So verbal response is lost when the induction dose of propofol is given. The endpoint of induction of propofol is verbal. Okay. So the respiratory depressant effect can cause apnea. It can cause bronchodilation. The best bronchodilator is ketamine, but propofol also causes bronchodilation. Bronchodilatory effect, bronchodilation in asthma and COPD patients, COPD and asthma patients. When we are talking about respiratory, it will indicate COPD and asthma. Okay. Then it also potentiates the hypoxic pulmonary vasoconstriction. Is this clear? Now we have then we have CVS, cardiovascular system. It decreases the blood pressure. How much? By 25 to 40% decrease in the systolic blood pressure. 25 to 40% decrease in systolic blood pressure. That is why it has a myocardial depressant effect. Depressant effect. So after induction, the BP will fall. Clear? Then it also decreases the cardiac output. Cardiac output is decreased. Stroke volume is decreased. Clear? The heart rate is decreased. Is that all right? Okay, that is about CVS. Then you also know that propofol has an antipruritic effect, itching. So let's go with the uses of propofol. Let's learn what are the uses of propofol. As we already know, it is an induction hypnotic agent. So it is used for induction at a dose of 1 to 2.5 mg per kg. 1 to 2.5 mg per kg IV. It is used as an induction agent, and it is also used as a maintenance agent. It is also used as a maintenance of anesthesia agent. Then it has an antiemetic effect. 10 to 20 mg IV. 10 to 20 mg IV can cause antiemetic effect. Clear? Then it can be used for sedation. When do you give sedation? For small diagnostic or therapeutic procedures. During small diagnostic, therapeutic or small surgical procedures. Okay. It can be used in ICU also. In ICU for mechanically ventilated patients. Alright. It is used as an antipruritic agent. Antipruritic, especially for patients with biliary cholestasis. Alright. Now what are the other uses? Your MCQ. The previous year question is, propofol is the agent of choice for daycare surgery. Agent of choice for daycare surgery. Patient is discharged on the same day, admitted in the morning, discharged in the evening. That is daycare surgery. Because due to redistribution, it has a very short duration of action. Okay, it has a pleasant recovery. Propofol has a pleasant recovery. So it can be used for daycare surgery. Okay, it has a shorter half-life, no residual effects, antiemetic effects. All these will help in daycare surgery. Next, it is also the agent of choice in case of asthma. If the patient has active asthma, ketamine is the agent of choice, but propofol can also be used in patients with asthma. Okay, agent of choice for daycare surgery and asthma also. But if patient has active asthma, then definitely ketamine is the bronchodilator of choice rather than propofol. Okay, am I clear? Next, let's talk about the side effects of propofol. What are the side effects of propofol? See, one thing you have to remember, discard the propofol vial if it has been 6 hours. If it has been 6 hours since the vial has been opened. Why? Because there is high chance of bacterial contamination once the vial is open. So discard the vial. Within 6 hours after opening. What is the reason? To prevent bacterial contamination. Alright. Then the propofol causes pain on injection. pain on injection. This is a previous year question. So that pain you can be, the pain can be passed by adding lignocaine 2% to the solution. Lignocaine 2% to the solution. Alright. Or a pre-treatment with ketamine or an opioid or tramadol also alleviates the pain in the pain on injection on propofol. Okay. Then propofol will cause apnea. Propofol can cause hypotension due to decreased cardiac output. Hypotension. Alright. Then propofol can cause thrombophlebitis. It can cause thrombophlebitis of that vein. Then it can also cause myoclonus sometimes, very rarely. Okay. Then propofol causes something called propofol infusion syndrome. Propofol infusion syndrome. This is rare condition. This is rare but lethal. Rare but lethal. When does it occur? It occurs when you give an infusion, a propofol infusion, it's more than 4 mg per kg per hour. More than 4 mg per kg per hour for more than 48 hours. For more than 48 hours. Alright. So what does it lead to? It leads to acute refractory bradycardia. Acute refractory bradycardia. Refractory bradycardia. Then it can cause metabolic acidosis. Metabolic acidosis. More than 10 millimole per liter base deficit. Alright, then it can cause hyperlipidemia. Clear? Then it can cause a fatty liver. It can cause rhabdomyolysis. Clear? It can cause acute cardiac failure. And this rhabdomyolysis can lead to green colored urine. Alright. Then it can cause hyperkalemia. And it can cause lipemia. Alright. This bradycardia can lead to asystole also. Patient can land up in cardiac arrest. So if a case is given or a clinical question can be given, patient is under anesthesia, given propofol, he landed up in asystole, what is the cause of this arrest? It can be the propofol infusion syndrome also. Alright. Or an ICU patient who is on ventilator, given propofol for more than 48 hours in the form of an infusion, what is that diagnosis can be asked. So what led to this? This is due to accumulation. Just remember that propofol infusion syndrome is due to accumulation of propofol metabolites. This will cause inhibition of mitochondrial enzymes and electron transport chain. This is the cause of propofol infusion syndrome. Treatment is treat the cause, stop the infusion, put the patient on a mechanical ventilator, intubate the patient if required, bradycardia, okay, start cardiopulmonary cerebral resuscitation. Alright. So now let's move on to the second class, which is barbiturates. So what was the first barbiturate to cause loss of consciousness? It is hexobarbital. Hexobarbital was the first barbiturate. First barbiturate is hexobarbital to cause LOC. Clear? Now the most importantly is the barbiturate we use regularly or nowadays is thiopentone or thiopental or thiopentone. Okay, the credit goes to Waters and Lundy. They introduced thiopentone in 1934. The barbiturates can be classified as thiobarbiturates or oxybarbiturates. Thiobarbiturates or oxybarbiturates. So what are the examples of thiobarbiturates? Your thiopentone, or there is thioamytal. Or amylal. And oxybarbiturates, you have methohexital. Methohexital is nothing but a barbituric acid with oxygen atom at C2 carbon. Okay, so it is a barbituric acid with oxygen at the second carbon atom, with oxygen at C2 carbon atom. Clear? So let us know more about thiopentone sodium. Availability. Thiopentone is available as a pale yellow powder. You can see in this picture, this is not a liquid. This is a pale yellow powder. Alright. So it is as a pale yellow powder. So you are going to mix it. You have to mix the powder with distilled water and normal saline, then form a mixture. Okay, form a solution. The barbituric acid with sulfur atom at second carbon. Sulfur atom at second carbon. This will lead to the formation of thiopentone sodium. Clear? The vials are available as 500 mg vial. It contains 6% sodium carbonate. 6% sodium carbonate. Clear? It is used as a 2.5% solution. 2.5% solution or 25 mg per ml. Each ml contains 25 mg of the drug. Alright, next, it can be diluted with 20 ml of distilled water. 20 ml of distilled water or sterile water. Diluted with sterile water. Alright. Use of crystalloids is avoided for mixing thiopentone sodium powder. Use of crystalloids, for example ringer lactate, is avoided because it can cause formation of precipitate. Now thiopentone is a highly alkaline solution. The pH is more than 10.5. Clear? Now what is the mechanism of action? Thiopentone also has a GABA mimetic action. It has a GABA mimetic action. Mainly acts on GABA receptors. So the sedative and hypnotic effect is due to action on GABA receptors, both sedative and hypnotic. Alright, then it also has an action on glutaminergic system or the NMDA system. That is inhibition of the excitatory neurotransmitters. Inhibitory action on the glutaminergic NMDA system. Inhibitory Inhibitory action on the neurotransmitters of glutaminergic system. Clear? Now moving on, let us know what is the effect of thiopentone on different organ systems. Effect on organ systems, or the pharmacodynamics. What is its effect on the central nervous system? It decreases the cerebral metabolic rate of oxygen. It decreases the intracranial pressure. So thiopentone has a very good cerebroprotective effect. Cerebroprotective effect. When is this useful? Whenever there is a cerebral ischemia, this is very useful. Cerebral ischemia. See, we already know that cerebral perfusion pressure is mean arterial pressure minus intracranial pressure. This is cerebral perfusion pressure. Now with barbiturates, the ICP decrease is more than MAP. MAP is mean arterial pressure. So with barbiturates, ICP decrease is more than MAP decrease. If this decreases, ICP decrease more than MAP, then automatically the cerebral perfusion pressure is increased, or it is preserved. So cerebral perfusion pressure is preserved using barbiturates. Clear? Then let's see about its effect on the EEG. There is a decreased EEG activity with thiopentone. Alright. And also it is a highly lipid soluble compound. Highly lipid soluble. When it is highly lipid soluble, automatically it will cross the blood-brain barrier. Highly lipid soluble crosses blood-brain barrier very rapidly. Alright. So this is cause of the rapid onset. This will cause rapid onset of action of thiopentone, which is in 15 to 30 seconds. 15 to 30 seconds, like propofol. So patient will become unconscious. For patient to become unconscious. So it has a rapid onset of action. These 15 to 30 seconds, it is nothing but the one arm brain circulation time. Okay. But it has a low duration of action. Which is again 5 to 10 minutes. Again, what is the reason? Because thiopentone also has a rapid redistribution. It is due to rapid redistribution of the drug. This is a previous year question. This is an MCQ. Okay. Rapid redistribution of the drug from CNS to other places. CNS to other tissues. That is why the drug is not being there in the CNS to act at the GABA receptors. Okay. That is why the duration of action is very low. This is due to redistribution to other tissues out of CNS. Clear? Thiopentone is also known as truth serum. It is used for narco analysis. This is just a point for general knowledge, won't be asked in your exam. So it is used for narco analysis. Then what is its effect on the CVS, cardiovascular system? Decrease cardiac output, decrease blood pressure. So it can cause severe hypotension, similar to propofol. It will cause hypotension. So due to this hypotension, there can be a reflex tachycardia. Which is increase in heart rate. Why is this the reflex tachycardia there? It is due to activation of the baroreceptors. Baroreceptor mediated reflex tachycardia can occur after giving thiopentone. Clear? Then what is its effect on the respiratory system? It is a central respiratory depression. central respiratory depressant. Respiratory depressant. For thiopentone, there is a peculiar feature which is known as double apnea. Double apnea. So what is double apnea? There is an initial period of apnea. In double apnea, there is an initial period of apnea which is followed by adequate tidal volume breaths. Initial apnea, then followed by adequate breaths, adequate tidal volume breaths. Then there is a prolonged apnea. This is known as double apnea caused by thiopentone sodium. Prolonged apnea. Alright. I hope this is clear. Then how is thiopentone metabolized? Metabolized by liver and kidney. It is metabolized by liver and kidney. Okay. And also remember that the barbiturates are hepatic enzyme inducers. Barbiturates, they are hepatic enzyme inducers. So that is the reason they are contraindicated in acute intermittent porphyria. You can use propofol but not thiopentone. Thiopentone contraindicated in acute intermittent porphyria. Clear? Contraindicated in acute intermittent porphyria. This question was asked previously. This is a previous year question too. Alright. Now what are the uses? It is used for induction as well as maintenance of anesthesia. Induction and maintenance. Of anesthesia. But it is always not the first choice of drug for induction. It is propofol. If first choice is given, then take propofol. Okay. Induction and maintenance of anesthesia. It is a drug of choice. For electroconvulsive therapy. Drug of choice for ECT or electroconvulsive therapy. Okay. It is given for schizophrenic patients or bipolar patients by the psychiatrists. Okay. For those patients, we give thiopentone as the induction agent. Drug of choice for ECT, which is methotrexate. The drug of choice for ECT is methotrexate. This is a previous year question. It was asked previously. Alright, this is important. It is given for schizophrenia patients and bipolar disorder patients. It has a fast onset, smooth induction. There is a rapid emergence. Emergence is also very rapid. Clear? Then what is the dose? It is 3 to 4 mg per kg in adults. For children, it is 5 to 6 mg per kg. Okay, 3 to 4 mg per kg IV in adults. Alright. Then what are the contraindications? Whenever there is a respiratory obstruction or inadequate airway. Respiratory obstruction. Because it causes apnea. So respiratory obstruction or inadequate airway. Since it causes huge hypotension, it is contraindicated in cardiovascular instability or in shock patients. Shock or cardiovascular instability. Avoid in case of status asthmaticus. Avoid him. In case of acute intermittent porphyria, AIP, acute intermittent porphyria, you can use thiopentone in case of porphyria cutanea tarda, but not in acute intermittent porphyria. So one exception is, except porphyria cutanea tarda, though you can use it in porphyria cutanea tarda, but not acute intermittent porphyria. And it is contraindicated when there is no emergency airway equipment. If you don't have emergency airway equipment, don't give induction agent to any patient as such. Okay, no emergency airway equipment. There is no emergency airway equipment. Alright, is this clear? Now let's move on. The final touch about thiopentone. What are the side effects? What are the side effects of thiopentone? Thiopentone has a garlic or onion taste. It will give a garlic or onion taste to the patient. Okay, onion taste to the patient. Then there is chance of anaphylaxis or allergic reactions. Then it can cause local tissue necrosis. On giving IV, it can cause local tissue necrosis. It can cause urticaria. It can also cause bronchospasm. That is why it is contraindicated in acute asthma. It can cause bronchospasm. Okay. Then suddenly, if you give someone place the IV cannula inside a artery and not in a vein, he put an IV cannula in the artery and you inject without knowing, unknowingly you injected the thiopentone into the artery. Then what happens? So let us see what happens when accidental intraarterial injection. Accidental intraarterial injection of thiopentone. So this will lead to endothelial injury and vasospasm immediately. So endothelial injury and vasospasm leading to thrombosis. Why is all this happening? This is due to the crystallization of the drug. So thiopentone will become crystallization of the drug. Very important, crystallization of the drug. Okay, so this is very dangerous to the patient. So how do you want to treat this condition? Okay, leave the arterial cannula in situ. Leave arterial cannula. Leave arterial cannula in situ. Okay, then give a saline flush. To dilute the drug. You want to dilute the drug. Clear? Then the next step, you do limb elevation. These are all the conservative managements. Limb elevation to prevent the venous thrombosis. Alright. Then if it is not relieved, we go for drugs. What are the drugs which can be used? Heparin. We can give heparin with lignocaine. 1000 to 2000 units of heparin. Okay. We can give phentolamine injection. Or papaverine injection. These are vasodilators. Then we can give some blocks which are cervical sympathetic block. Or you can give brachial plexus block. And you can also give stellate ganglion block. These all will also lead to vasodilation. Alright. So what is ketamine? Ketamine is a phencyclidine derivative. There are so many questions on ketamine in the examination, so listen carefully. So ketamine is a phencyclidine derivative. It is a S plus isomer. It is a stereoisomer which is more potent, okay, than R minus isomer, R negative isomer. So S plus isomer is more potent than R negative. Why? Because it has less psychomimetic actions. less psychomimetic effects. That is why we prefer S plus isomer. Clear? Then how is ketamine available? It is available as 50 mg per ml vial. There is a solution, a colorless liquid, 50 mg per ml vial available. It is a clear liquid. It is a clear liquid. Okay. Ketamine can be given IV, it can be given IM, it can be given oral, it can be given rectal, it can be given transcutaneous, it can be given intrathecal or spinal, it can be given through spinal, intrathecal, it can be given through epidural. Alright, but intrathecal and epidural, it must be preservative free solution. Preservative free solution can be used. Next, what is the mechanism of action of ketamine? Mechanism of action. Its main mechanism of action is on NMDA receptors. This is a PYQ. NMDA receptors, which will cause unconsciousness. Sometimes it also acts on opioid receptors. It also has action on opioid receptors, and that is the reason why ketamine can also provide analgesia. Unlike propofol, ketamine can provide analgesia and hypnosis both, because its action is at NMDA and opioid receptors also. So it can produce analgesic effects also. Alright. Then what are the systemic effects of ketamine or pharmacodynamics? Systemic effects. Let's talk about the central nervous system, CNS. It produces something called as dissociative anesthesia. Ketamine produces a dissociative anesthesia. Dissociative anesthesia. So what happens in dissociative anesthesia? The patient is in a cataleptic state. That is, the patient will resemble normal sleep. He will have adequate analgesia, but he will keep his eyes open. Okay, he'll keep his eyes open and maintain some reflexes, the swallow reflex. Okay, what is cataleptic state? Patient will remain asleep, but it will resemble normal sleep. Okay, resembles normal sleep. Patient will have profound analgesia. He will keep his eyes open, and he will maintain reflexes. What reflexes? The swallowing reflex and cough reflexes are intact. All these reflexes are intact. This is known as dissociative anesthesia. Okay, what is the cause of this dissociative anesthesia? It is due to something known as functional dissociation. This is due to functional dissociation. Of thalamocortical system from limbic system. Thalamocortical system from limbic system. Thalamocortical from limbic system. That is depression of the cortex and thalamus. And there is stimulation of the limbic system. This is the cause of this dissociative anesthesia. Okay, and ketamine is also a highly lipid soluble drug. So it crosses the blood-brain barrier easily. Rapidly crosses blood-brain barrier. Therefore, the onset of action is also fast. 30 to 60 seconds onset of action is also very fast, and also the peak effect is reached very fast. Peak effect within 1 minute. Peak effect within 1 minute. Okay, so ketamine causes dissociative anesthesia. This is very important. It was a previous year question to dissociate. Which of the following causes dissociative anesthesia? The answer is ketamine. Now moving on. How does it affect the other cerebral parameters? It increases the cerebral metabolism. Unlike thiopentone and propofol, it increases the cerebral metabolism. Cerebral metabolism. This will cause increased cerebral blood flow, increased intracranial pressure, increased ICP, increased CMRO2. Cerebral metabolic rate of oxygen is also increased. The EEG activity is also increased. Okay, there is a increased theta wave activity, and also there is a petit mal seizure like activity. Okay, EEG activity is also increased. Increased theta activity and petit mal seizure like activity. Petit mal seizure like activity. Then what is its effect on the cardiovascular system or CVS? Ketamine increases the blood pressure. Ketamine increases the heart rate, increases the cardiac output. Why are all this? This is due to the activation of the sympathetic system after ketamine. Activation of sympathetic system. So what happens? There is release of catecholamines. Catecholamines will act on the heart and blood vessels, and it will increase heart rate and cardiac output. Sympathetic system. Alright. This is due to initial release of catecholamines. But when all these catecholamine stores are depleted, the catecholamine stores are depleted, it will cause cardio depression. Cardio depression occurs when all catecholamine stores are depleted. Clear? This can also occur in a denervated heart. There is no release of catecholamines, or there is very less catecholamines. Okay, in that case, even ketamine will cause cardiac depression. Remember this. And also, it will cause increased myocardial oxygen consumption. Alright. Then moving on to respiratory system. Your previous year question, which of the following is the least respiratory depressant? The answer is ketamine. Least respiratory depressant. Answer is ketamine. Ketamine causes increased salivation. So what do you do for that? You pre-treat the patient with atropine or glycopyrrolate, the anticholinergic drugs. Pre-treatment with atropine or glyco will decrease the salivatory effect of ketamine. Alright, and also this salivation increases the amount of secretions that are getting the secretions, all the secretions get pulled up, and it can lead to something known as laryngospasm also. So pre-treatment with atropine and glycopyrrolate is very important before giving ketamine. And now ketamine is a bronchial smooth muscle relaxant. And that is the reason it is preferred in asthma patients, status asthmaticus. It is very much preferred in bronchospasm conditions. Okay, preferred for acute asthma or status asthmaticus, and it is also the drug of choice in case of bronchospasm. Drug of choice in asthma patients, acute asthma. Drug of choice in status asthmaticus is ketamine. Drug of choice. This is also a previous year question. While giving ketamine, all the airway reflexes are preserved. airway reflexes are preserved, and that is the reason it can prevent aspiration in case of full stomach patients. Airway reflexes are preserved. The patient has his control over his airway reflexes, so it can be used in full stomach patients. For rapid sequence induction also, ketamine can be used as an induction agent. Okay, full stomach patients. It improves pulmonary compliance. Alright, now let's move on to the uses of ketamine. What are the uses of ketamine? It is used as an induction agent and a maintenance agent. Induction and maintenance of anesthesia or general anesthesia. Clear? It is an agent of choice. When the patient has a reactive airway disease like asthma, in case of reactive airway disease, when the patient has a trauma with shock, reactive airway disease, patient is in shock because it has a sympathetic action, increases the blood pressure, heart rate. So when patient is shocked due to trauma, ketamine can be used. It is an agent of choice in case of congenital heart disease. In patient with cardiac tamponade. In case of a patient with restrictive pericarditis. Okay, in congenital heart disease, the right to left shunts. So in all these conditions, the agent of choice is ketamine. Clear? Then it can be used for sedation and analgesia. Okay, ketamine also provides an alternative method of induction for children. Usually we give induction either inhalational route or IV route, but through ketamine you can also induce the child through IM route, intramuscular route induction, that is intramuscular route for children. Is this clear? Then it is also used for pain management. We have already learned that ketamine has an action on opioid receptors, so it will give analgesia. For pain management also ketamine is used. What pain management? For post-operative pain. It is a constituent of multimodal analgesia. Post-operative pain. It can also be used for cancer pain. It can also be used for cancer pain management. It can also be used for neuropathic pain management. Clear? Now, are there any contraindications for ketamine? Absolutely. In case of increased ICP, like a patient came with brain injury, if the question mentions brain injury, then ketamine is contraindicated. Where there is already increased ICP, you don't want to increase the intracranial pressure more by giving ketamine. So, in case of brain injury, avoid. Okay. And in case of open eye injury or open globe injury, avoid ketamine. Open eye injury, like a patient with glaucoma, open eye injury or glaucoma, where there is already increased intraocular pressure. Intraocular pressure is already increased. By giving ketamine, we don't want to increase the IOP more. Don't give ketamine in case of ischemic heart disease. In case of vascular aneurysms. In case of psychiatric patients, already patient is on having delusions, hallucinations, post-operative delirium is caused by ketamine. So avoid in case of psychiatric patients or schizophrenic patients. Okay. schizophrenic patients or any other psychiatric disorders. Avoid in case of severe hypertension. Already patient has severe hypertension. Avoid ketamine. Also remember that ketamine shows a neuroprotective effect in patients with head injury, but with patients on mechanical ventilation. Okay, this raised ICP due to brain injury occurs in patients with head injury who are on spontaneous ventilation or who are breathing spontaneously. In them, ketamine is contraindicated. But in case of patients with head injury who are on mechanical ventilation, the report says that ketamine has a neuroprotective effect. So this is for spontaneously breathing patients. For mechanically ventilating patients, ketamine also has a neuroprotective effect. This is the research, because it retains the response of cerebral blood flow to oxygen. In mechanical ventilated patients, ketamine will retain the response of cerebral blood flow to oxygen. Alright, now moving forward. So what are the side effects of ketamine? This is your previous year questions. Which of the following causes post-operative delirium? The answer is ketamine. Ketamine causes post-operative delirium. It causes undesirable psychological reactions. Undesirable psychological reactions. What are they? They are known as emergence reactions. Occurs during emergence from ketamine. Emergence reactions like vivid dreaming, hallucinations, illusions. Okay, a sense of floating out of the body. It can cause excitement, confusion, fear. Okay, fear, confusion, excitement. If all these features are given and you will be asked what drug might have been given during the anesthetic management which might have caused all these effects in the post-operative period in the patient, then your answer must be ketamine. Okay, excitement. So to prevent all this, we give pre-treatment with a benzodiazepine like midazolam to prevent all these unwanted effects. So treatment or pre-treatment with benzodiazepine. That is the reason in the pre-medication we give benzodiazepine whenever we give ketamine. So two drugs, ketamine and glycopyrrolate or atropine. Ketamine, while you give ketamine, you give pre-medication with benzodiazepine and anticholinergic drug like glycopyrrolate or atropine. Very clear? Now let us move on to our next drug, which is etomidate. The next drug we are dealing is with etomidate. Etomidate, it is a imidazole derivative. How is it available? It is available as a 0.2% solution, liquid, 0.2% solution, clear solution. Okay, this is also a lipid emulsion. Sometimes etomidate is also available in the form of a milk color liquid or white color liquid. Sometimes it is also available as white colored liquid. When it is in the form of a lipid emulsion, it is available as a white colored liquid. So don't get confused with propofol. What is its action of the CNS? Similar to propofol, it acts on GABA receptors, which will lead to hypnosis. This will cause hypnosis. Decreases the cerebral blood flow, decreases the CMRO2 again, decrease CMRO2. Okay, decrease the intracranial pressure, but one good thing about this is it will preserve the MAP. It will preserve mean arterial pressure, which is unaffected, and that is the reason etomidate is a cerebroprotective also. This is also a cerebroprotective drug. cerebroprotective drug. Okay. Next, moving on to cardiovascular system. Which of the following is the most cardiovascular stable induction agent? The answer is etomidate. Okay. Most cardiovascular stable or most cardiostable drug. Most cardiostable drug. This is a previous year question. It is etomidate. Why is it most cardiostable? Because it lacks the effects on the sympathetic nervous system. Because lacks effect on sympathetic nervous system and also baroreceptors. So it does not increase or decrease heart rate. It is very cardiostable. Etomidate. It maintains myocardial oxygen supply demand ratio. Maintains myocardial oxygen supply and demand ratio. Alright, and it is also preferred in vascular and ischemic heart disease patients. It is preferred agent in valvular or ischemic heart disease patients. Valvular or ischemic heart disease patients. Is this clear? Next, we have respiratory system. It has very less effect on the ventilation. No much change. Less effect on ventilation. That is a very good thing about etomidate. Then it also has some endocrine effects. This is to be remembered very importantly. Endocrine effect. What effect? It causes adrenocortical suppression. So etomidate causes adrenocortical suppression. So which of the following drugs will cause adrenocortical suppression? Answer is etomidate. Okay. This is a previous year question and it is a very important question. It causes reversible inhibition. Inhibition of an enzyme during the synthesis of cortisol from cholesterol. An enzyme which is involved is 11-beta hydroxylase. Okay, etomidate inhibits this enzyme 11-beta hydroxylase while conversion of cholesterol to cortisol. That is the reason it causes adrenocortical suppression. Clear? Now what are the uses of etomidate? It is used for induction of anesthesia. At 0.2 to 0.6 mg per kg dose. IV 0.2 to 0.6 mg. It has a rapid onset of action which is again 10 to 15 seconds. Okay, it can be used for cardiovascular compromised patients. Okay, it can be used for cardioversion. I'll write the dose once again. So the dose is 0.2 to 0.6 mg per kg. Clear? Moving on. It can be used for treatment of hypercortisolemia because it causes adrenocortical suppression. So sometimes it can be used for hypercortisolemia also. What are the side effects of etomidate? It can cause post-operative nausea, vomiting. Like propofol, etomidate injection is also painful. We have already seen that it is a lipid emulsion. So it can cause pain on injection. Again, this also needs a pre-treatment with IV lignocaine. Then it can cause hiccups. It can cause myoclonic movements. Undesirable myoclonic movements. Pain on injection, this is important. Then myoclonic movements, this is very important. Okay, so you have to give pre-treatment with midazolam. Again, pre-treatment with midazolam. 60 to 90 seconds before injection. 60 to 90 seconds before injection. Then it causes adrenocortical suppression. We have already seen adrenocortical suppression. Alright. Dexmedetomidine. Dexmedetomidine is an alpha 2 agonist similar to clonidine. Okay, it is a selective alpha 2 adrenergic agonist. Highly selective, actually. Highly selective than clonidine. Alright. It is used as a sedative. It is a hypnotic, analgesic, and a sympatholytic drug. Sedative, hypnotic, analgesic, and sympatholytic drug. Then mechanism of action: it acts on the locus ceruleus. Okay, it acts in the brain at the locus ceruleus, and it also acts on the spinal cord. Okay, dexmedetomidine is a drug of choice for conscious sedation. Alright, for conscious sedation, this is important. Since it causes sympatholysis, the side effects of dexmedetomidine, or it causes bradycardia. It can cause bradycardia. It can cause hypotension. It also causes some minimal respiratory depression. Effect. It can cause dry mouth. Okay. So what are its uses? It can be used for sedation in ICU, especially in mechanically ventilated patients. Mechanically ventilated patients. All right. Droperidol. This is a butyrophenone derivative. It has an antiemetic and sedative activity. Okay, it acts on the GABA receptors in the CNS. GABA receptors. What are its uses? It has an antiemetic action, so post-operative nausea, vomiting prevention, PONV prevention. Can be used for pruritus, secondary to opioid administration. Pruritus, which occurs as a side effect for opioids, this can be used for opioid administration. Alright, it is a sedative drug. It can be used for something known as neurolept analgesia. This is a state of sedation plus analgesia. Neurolept analgesia is sedation plus analgesia. A state of sedation plus analgesia. Clear? This is also known as tranquilizer. Okay, so droperidol tranquilizer, when you give it with fentanyl, when you give it in combination with fentanyl, it is known as Inovar. Okay, a tranquilizer like droperidol and fentanyl in a combination of 50:1. In a 50:1 combination, it is manufactured as Inovar. This is used for neurolept analgesia. analgesia, and also there is something called as neurolept anesthesia. Both are different terms. In neurolept anesthesia we add droperidol, then we have fentanyl, and if you also add nitrous oxide N2O for amnesia, then this is known as neurolept anesthesia. Okay, neurolept analgesia and neurolept anesthesia. I hope this is clear. Then there is one side effect. For droperidol. It causes QT prolongation, or torsades de pointis, QT prolongation. Alright, now the last topic for today is benzodiazepines. Clear? We have three famous benzodiazepines: the midazolam, lorazepam and diazepam. Okay. So benzodiazepines are used for sedation and mainly anxiolysis for relieving the anxiety of the patient. Alright, they act on GABA receptors. They again act on GABA receptors in CNS. They are not commonly used for induction of anesthesia, but they are used for anxiolysis and sedation. Clear? Then what are the drugs available? Midazolam, which is the most commonly used drug is midazolam. It is used as a pre-medication before general anesthesia. Most commonly used for pre-medication before general anesthesia. Clear? Then the other drugs are diazepam, lorazepam. Alright. Then there is temazepam. Then there is remimazolam. Alright. Midazolam, lorazepam, diazepam. These are the most commonly used drugs. So midazolam is a short-acting drug. Okay. Lorazepam is an intermediate-acting drug. And diazepam is a long-acting drug. Clear? And midazolam is fast-acting, short-acting and fast-acting. Okay. Lorazepam can be used in cardiac surgery. Why? Because it causes prolonged anxiolysis, not a short acting like midazolam. Causes prolonged anxiolysis. Clear? Then where are these drugs metabolized? Metabolized in the liver metabolism. Alright. Next, what is the order of potency of these drugs? Lorazepam more than midazolam, more than diazepam. Clear? Midazolam can be given in the form of IV. It can be given as oral supplementation, or it can be given as intranasal spray. Okay, it is used for pre-medication for anxiolysis and sedation. Okay, it can also be used as anticonvulsant. Okay, it also decreases the post-operative nausea, vomiting. It can be used for amnesia. This is important. And it can cause sympatholysis. Anxiolysis is nothing but it causes sympatholysis. Clear? What are the side effects? There is a dose-related depression. When you give more dose of that drug, it causes more respiratory depression. Dose-dependent respiratory depression will occur. Then it can also cause like not midazolam but lorazepam and diazepam have reported that they might cause venous irritation and sometimes thrombophlebitis. Okay, not with midazolam but loraz and diazepam. The injections can be painful. They can cause thrombophlebitis and can cause venous irritation. And they can cause venous irritation. Clear? And the last thing is remimazolam. 2 points about remimazolam. The name remimazolam, remifentanil and midazolam. Remifentanil is an opioid, midazolam is a benzodiazepine. Okay, so it is an ultra short acting benzodiazepine. The question, if remimazolam is given, it is a benzodiazepine. It is an ultra short acting benzodiazepine. It is metabolized not in the liver but by a plasma non-specific esterase. It is metabolized by esterases. Metabolized by plasma non-specific esterase. This can be a question. This is very important. And it has a faster recovery, ultra short acting, so faster recovery than midazolam. Than midazolam. And finally, let's know 1 point about flumazenil. It is a benzodiazepine antagonist. So 0.2 mg of the drug, maximum dose is 3 mg, 0.2 mg or maximum 3 mg. It is used for the reversal of benzodiazepines. Flumazenil, मज़े को नील करने वाला drug is flumazenil, benzodiazepine antagonist. Clear? Just a list of painful injections. What are the painful injections or painful medications? Propofol, methotrexate, etomidate, diazepam. These are the injections which are painful. And also there is rocuronium, which is a muscle relaxant. We'll be dealing later. This is also a painful injection. Alright, so this brings us to the end of the video. I hope you found this video helpful. I want you to like this video, share with your colleagues and friends, and do follow us on Instagram at Anesthesia Notes page. Okay, so meet you till the next video. Thank you.